Good afternoon, ladies and gentlemen. My name is Garrett C. From the Tianjin Medical University in China and also the Kent and Medway Medical School in the UK. And first of all, I'd like to thank the organizing committee of the 13th Asian Conference on Pharmacoepidemiology 2021 for the very kind invitation and the opportunity to speak about our work in this session. And in particular, I would like to thank Professor Shin and Dr. Zhong for the tremendous efforts in making sure that this session goes smoothly. So the topic of my presentation is going to be statin use and severe COVID-19 disease insights from Hong Kong, China. So the plan of the talk is to firstly provide an overview on the roles of statin in COVID-19. Secondly, it is to review some of the existing studies that have examined the relationship between statin use and adverse outcomes in COVID-19. And finally, we would like to report on our findings from our population-based cohort study using electronic health record data from Hong Kong. So some very brief introduction for the effects of statins. So we all know that in addition to lowering cholesterol levels, statins have now been shown to have pleiotropic effects. So specific to COVID-19, it's been shown in basic science studies to limit the entry of the SARS-CoV-2 virus and also its replication through the inhibition of the main protease and also the RNA-dependent RNA polymerase. And eventually, the cascade of effects lead to inhibition of the toll-like receptor 4 and thereby reduction in the interleukin-6 levels, which together would modulate macrophage activity. So statins can also reduce the complication rates in COVID-19, and these include thrombosis and pulmonary fibrosis through a reduction in serum PAI1 levels, and also attenuation of transforming growth factor and also vascular endothelial growth factor pathways in the lung tissue, and improving endothelial function. So previous cohort studies have been conducted looking at the relationship between the use of statins and adverse outcomes. So that there have been some published systematic reviews and meta-analyses which have demonstrated conflicting results. So in the pooled analysis of 35 studies, the use of statins was associated with significantly lower risks of all-cause mortality and also the composite endpoint of severe illness in COVID-19 compared to non-statin users. And in another meta-analysis of 35 studies, statin use was not associated with an improvement in the poor composite outcomes in COVID-19. So the differences mainly lie in the numbers extracted, and so the adjusted odds ratio were extracted in reference 1, and whereas the unadjusted odds ratios were extracted for reference 2. So clearly some of the differences are likely due to the presence of comorbidities and other imbalances between the statin exposure and non-exposure groups. So in terms of the Hong Kong study that we are going to present, so this was a retrospective study of all patients that underwent COVID-19 RT-PCR testing between January 2020 and also December 2020. So in Hong Kong, all of the public hospitals, as well as the outpatient or ambulatory care facilities, are linked together. So, for example, if you attend one hospital and gets discharged and then reattends another hospital in the public sector, then all of the attendances are linked. And with this system, we were able to look at clinical details and including ICD-9 diagnoses. And also we have pathology reports, so all of the complete blood count, renal function, liver function tests, these can all be collected and extracted. And we also have a pharmacy module, so that includes all of the pharmacological and medication treatments. And the system captures all of the PCR tests performing in the sector, so that includes A&E, outpatient, and inpatient settings. So as long as they were conducted in the public sector, they were included in the cohort. And in terms of severe disease outcomes, ICU admission is a routinely collected variable, and mortality data is also linked to the local government registry. So there's very well coded data in the system. So what we extracted in the study was patients' demographics, prior comorbidities, hospitalization characteristics before admission for COVID-19, prescription of different medications, as well as laboratory tests. And our primary outcome was a composite outcome of either need for intubation or all-cause mortality within 30 days. And we conducted one-to-one propensity score matching between statin users and non-users based on age, sex, Charlson comorbidity score, medical comorbidities, as well as various classes of medications that have been previously been shown to influence or modify the outcomes of COVID-19. And we applied logistic regression and as well as Cox regression to look at the significant predictors of the severe disease outcome. So we identified around 6,100 patients hospitalized for COVID-19, and we narrowed down the cohort to analyze only those who were symptomatic, so those that required either steroid or antiviral treatment. And this was around 2,600 patients. And because we thought that there might be some differences between antecedent and inpatient statin users, we also separated the analysis. And within each cohort, we conducted one-to-one propensity score matching based on the age, sex, comorbidities, and other medication use. So in terms of the characteristics before matching, so you can see that in the statin users, they tended to be a lot older, and also they had a high Charlson comorbidity score, as well as high number of medical comorbidities. And we also listed out the percentages of the various medical conditions here. So you can see that the standardized mean difference was greater than 0.2 for a lot of these variables, but the imbalances between the user and the non-user groups were significantly reduced. So the SMD was less than 0.2, indicating successful matching. And so that goes the same for the medication use. So the SMD was significantly lower by the matching. And so these are the blood test results. So we didn't match for the blood test, so I won't go into these in any further detail. So in terms of the outcomes for antecedent statin use, so there was, before the matching, there was around 3% of patients who have suffered the composite outcome. For the non-statin users, this was a lot higher, around double that, in the 6% range. And you can see that after the matching, there was actually greater differences observed. So there was the event rates were a lot higher in the non-exposure group. So you can see here in the survival curves, both before and after matching, there was a significant lower risks and the occurrences of the severe disease outcome in the statin users, as reflected by the blue line here. And you can see that with the non-statin exposure group, the event rates were significantly higher. So the survival was lower, both before and after matching. And in terms of inpatient statin use, there were also not notch differences in terms of the findings compared to the antecedent statin user cohort. So both before and after matching, the statin users suffered significantly lower event rates for severe COVID-19 disease, both before and after propensity score matching. In terms of the logistic regression and Cox regression results, we showed that whether the patient had antecedent or inpatient statin use, they were associated with lower odds or risk, so there should be a hazard ratio of the severe COVID-19 disease, both before and after propensity score matching. So you can see that after matching, the differences were actually more pronounced. So we do wonder whether the potential bias in the data set. So before publishing these results, we are going to expand the data set. So we have around 6,000 more patients since the last recruitment date, and we're going to use 1 to 2 propensity score matching to make use of the data in the non-statin exposure group. So we look at further analyses using multivariable adjustments and match cohort. So there are some differences in opinions whether we should do this. So some reviewers say that we shouldn't do it because it's already been matched, whereas other reviewers say, well, there are also some potential imbalances after matching, so you should look at adjustments in the match cohort as well. And in any case, we're also going to look at other propensity score methods, such as weighting and stratification. So, ladies and gentlemen, so hopefully we've shown some convincing data to show that both antecedent and inpatient statin use are associated with the decreased risks of severe COVID-19 disease. And in terms of the mechanisms, it's most likely due to the anti-inflammatory and the immunomodulatory actions of statins. So in severe COVID-19, there's extensive systemic inflammation characterized by raised C-reactive protein and also interleukin-6. So for statin users, they have been shown to have lower levels and also a faster downward trajectory of these above inflammatory markers, so CRP and IL-6, compared to non-statin users. And there's also a partial resolution or reduction in metabolic dysfunction through the reduced activation of the NLRP3 inflammasome pathway and the subsequent release of pro-inflammatory cytokines. Statins have also been shown to slow or to prevent the progression of acute respiratory distress syndrome. And in terms of who are likely to respond to the statins, there is a hyperinflammatory subphenotype that have been characterized, and they've been shown to have or show greater sensitivity to the statins actions. So in terms of strengths and limitations of our study, so the strengths include comprehensive coding COVID-19 tests. So because all of the public sector records are linked, so if they were done in the public sector, they would have been coded into the system with minimal loss of cases. So in terms of outcomes, these are hard outcomes that are routinely coded, and these include admission to ICU, the need for intubation, and also mortality. So there is minimal misclassification bias. And we also have a lot of follow-up data after COVID-19 positivity, although in this particular study, we only looked at 30-day mortality because we believe that that's most likely to be related to severe COVID-19 disease. So in terms of limitations, because this was a retrospective cohort study, we can only look at the association between statin use and adverse outcomes. So if we do want to look at causality, we need to look at randomized controlled trial settings. So in terms of another limitation, we have a rather small cohort size in this study, and so we are going to expand that study and to confirm the whether the findings are true in the larger cohort. So in terms of medication compliance data, they're not available for antecedent use. That's partly why we also looked at inpatient use, because inpatient use is monitored by the nursing staff and the medical staff. So if a patient is prescribed a drug but not given, then this would appear in our drug records. And in our study, we were only looking at shorter term outcomes, so we haven't looked at less severe outcomes, such as long COVID or the impact of COVID-19 on outcomes such as mental health outcomes. So we plan to do that in future studies. So in conclusion, then so statin therapy is associated with lower risks of severe COVID-19 disease. So we do need further basic science and translational studies to unravel the underlying mechanisms. And in terms of what we can do in the risk prediction front, so I believe we should incorporate pharmacotherapy into this existing risk models. So in addition to antihypertensive use, as well as anticoagulant or anti-platelet use, because statins are a potential disease modifier, this should be included in the predictive risk models. So acknowledgement, so all of the work that I've described in this presentation is due to long periods of teamwork. So I'd like to thank especially the first author, Dr. Jiandong Zhao from our team, who's a data scientist, and also medical students from Hong Kong, so Sharon, Keith, and Teddy. And we have also received a lot of input from collaborators in China. So Professor Liu Tong is a cardiologist in Tianjin, Abraham Wai, who's an emergency physician, and Carlin Zhang, who's a neurologist, Professor Ian Wong, who is a clinical pharmacist and epidemiologist, Professor Bernard Zheng, who is a clinical pharmacologist, and Professor Chengping Zhang, who's a data science professor, all of whom have had tremendous input into this study. So thank you very much for your attention, and I'll be very happy to take any questions. So thank you very much.